Hi, class. Today we are going to be talking about urinary output drugs. We have some learning objectives. We are going to identify core knowledge on drugs that affect diuresis, identify patient variables related to these drugs, describe nursing interventions to maximize therapeutic effects of drugs that affect urinary output, and determine key teaching needed for the patient. We have some vocabulary terms that go along with this. The first one is diuresis. Diuresis means ridding the body of fluids. This is done via the kidneys by increasing the excretion of water and electrolytes. What electrolyte does water follow? Sodium. This is a homeostatic mechanism for maintaining fluid balance. Diuretics. A diuretic is a drug or substance that causes diuresis. Diuretic drugs are used to decrease the body's fluid volume when it cannot regulate effectively. Next up, we have edema. Edema was called dropsy long ago. It is swelling caused by fluid retention that can occur in legs, feet, hands, face, or really any part of the human body. Edema can be caused by many different things: heart failure, kidney failure, liver disease, thyroid disorders, blood clots, poor or high salt diet, or medications. Edema increases the workload of the heart and therefore decreases tissue perfusion. Hypervolemia is an increase in circulating blood volume in the body. This can be caused by excess water and sodium retention and can lead to edema. Osmolality is the concentration of a solution. When more water is reabsorbed by the kidneys, the osmolality of the urine increases. It gets more concentrated. So in other words, if our kidneys are keeping more fluid in the blood, then the blood is going to be more dilute, but the urine is going to become more concentrated. So when the urine is more concentrated, because we're holding on to that fluid, then the osmolality of the urine is increased. Does that make sense? So let's start out with a little review of the renal system. The renal system consists of the kidneys, ureter, and bladder. The kidneys are an important part of maintaining your body's health. The kidneys filter waste products, electrolytes, and water out of the blood and excrete them in urine. The kidneys also play a role in maintaining acid-base balance in the body and in maintaining blood pressure. Our bodies have two tubes called ureters that transport waste and fluids from the kidneys to the bladder. The bladder is a sac-like organ that stores urine prior to excretion. So urine formation. Urine is formed in the kidneys through three complex processes: glomerular filtration, renal tubular reabsorption, and renal tubular secretion. These all take place in the nephron of the kidney. In the nephron, water and solutes are filtered through a glomerular membrane known as Bowman's capsule. This membrane does not allow blood cells or plasma proteins to pass through it. The average glomerular filtration rate is 125 milliliters per minute. 99% of the plasma that is filtered through this through the glomerular filtration is reabsorbed into the bloodstream. So this filtrate is converted into urine. The part that is kept is converted into urine in the renal tubules. During renal tubular reabsorption, molecules move across a semipermeable membrane from the renal tubule to the peritubular blood via diffusion and active transport. During renal tubular secretion, molecules move from the peritubular blood into the renal tubular. In all of this, antidiuretic hormone plays a large role. When the osmolality of the extracellular fluid increases or becomes more concentrated, ADH is released. ADH is antidiuretic hormone. ADH increases the permeability of the kidneys collecting tubules to water, meaning more water can be reabsorbed. When more water is reabsorbed into the body, the urine's osmolality is increased, like I said earlier. The tubes are impermeable to water without ADH. So no water is reabsorbed and the urine gets very dilute because all the water that's filtered is flushed out. So there's the kidney. You see that it's a cross section of the kidney, and it shows you a little part of the nephron where the glomerulus is and the tubules. So that's one nephron that you're looking at, and the blood it goes into the glomerulus, filtered through there, goes through the tubules, and then comes out as urine. So there's a whole bunch of nephrons in that kidney. And you can even see on the slide how the blood is coming in through the red artery and leaving through the blue vein. Here is a bigger picture of the nephron. And again, you see the red and the blue arteries and veins. You see the efferent and afferent arterioles. You see the glomerulus and Bowman's capsule, and the path of the urine through the proximal tubule, through the loop of Henle, up to the distal tubule, and into the collecting tubule. And even this picture shows you where some of the different diuretics work. So you see loop diuretics work down by the loop of Henle, thiazide diuretics work in the distal tubule, potassium sparing diuretics work down by the collecting duct. So some diseases and health disorders, congestive heart failure, CHF, nephrotic syndrome, kidney diseases, both acute and chronic, hypertension, edema, glaucoma, hypervolemia, which means too much fluid in the body, electrolyte disorders, overactive bladder, epilepsy, increased intracranial pressure. All of these things are helped by these kind of drugs that we're talking about in this chapter. So these are just some examples of diseases that can have an effect on urine output or vice versa. In congestive heart failure, for example, ineffective pumping of the heart leads to decreased Ineffective pumping of the heart leads to decreased cardiac output, meaning the heart isn't pumping efficiently and it can't pump the blood out to where it needs to. So this leads to fluid volume overload in the body. And even though there's all this blood and there's all this volume, your heart's not pushing it where it needs to go. So there's still decreased blood supply to vital organs like the kidneys. This diminished blood supply impairs glomerular filtration rate, and the kidneys think this decreased flow is due to hypovolemia. So the kidneys think they're not getting enough blood supply because the body doesn't have enough fluid. So then the kidney's response is to retain water and sodium, which unfortunately makes the CHF worse because we're retaining more water. So our hypervolemia from the CHF is worsened. Another example is nephrotic syndrome. The most prominent sign of nephrotic syndrome is edema. So it's a kidney disorder that alters glomerular filtration to proteins. So the proteins that normally aren't filtered through the kidneys or can't get through that membrane are. So we lose protein in our urine, which is called proteinuria. This leads to low albumin, or protein, in the blood, which is called hypoalbuminemia. This allows fluid to leak out of the vessels and into the tissue, which causes edema and hypovolemia. The kidneys compensate this by retaining water and sodium, again, which leads to more edema, unfortunately. So what do we do about these things? We use some urinary output drugs. Urinary output drugs, most of urinary output drugs, I guess, are diuretics. So we have thiazide diuretics, loop diuretics, potassium-sparing diuretics, osmotic diuretics. We're going to break those down and talk about each class. And then we have carbonic anhydrase inhibitors and anticholinergics. The diuretics work by decreasing renal reabsorption of sodium and promoting excretion of water. The greater the amount of sodium excretion, the greater the amount of water excretion, because water follows salt. This process can cause the reabsorption of other electrolytes, like potassium, to decrease and promote their excretion as well. Each type of diuretic works differently, and they are prescribed based on the patient's medical problems and the desired therapeutic effect. So meaning they're prescribed based on what's wrong, but also what we need to happen. These drugs are used to treat blood pressure, edema, CHF, intracranial pressure, intraocular pressure, pressure in the eye, and glaucoma. Carbonic anhydrase inhibitors are mostly used to decrease intraocular pressure, and anticholinergic drugs are used to treat overactive bladder. So first, we're going to talk about diuretics. And this picture shows what a leg with edema compared to a normal leg looks like. So if you haven't seen that before, that's what that is. The first class of drugs we're going to talk about is the largest class of diuretics. These are thiazide diuretics. Hydrochlorothiazide is the prototype drug for this class. It acts mainly on the distal convoluted tubule, and it works by inhibiting sodium reabsorption and increasing calcium reabsorption. So it's administered orally, and it's mainly hydrochlorothiazide, also known as HCTZ, is mainly used to treat hypertension. It can take several days of taking this drug to see that blood pressure start to get lower, and actually a couple weeks to get the full effect of the drug. It can be used to treat edema from CHF, cirrhosis, or estrogen therapy also. As moderate diuretics, thiazide diuretics are less potent than loop diuretics. Even at maximal doses, they can only inhibit 3 to 5% of the filtered sodium present in the tubular fluid. Thiazide diuretics impair sodium and chloride reabsorption. They also impair magnesium, but increase calcium reabsorption. So contraindications of thiazide diuretics. HCTZ is contraindicated in severe renal disease because it is metabolized by the liver and excreted in the urine. It is also contraindicated in a patient with anuria, which means they aren't producing urine, and in patients with a sulfonamide allergy because the chemical makeup is similar to sulfonamides. It crosses the placental barrier and is secreted in breast milk, so it should be used with caution in women who are pregnant or breastfeeding. Most adverse effects from this drug are related to fluid loss or electrolyte imbalances, and they include muscle cramps related to potassium loss and gout related to increased uric acid levels. But you see them listed up there: vertigo, nausea, vomiting, aplastic anemia, thrombocytopenia. There are multiple drugs that can interact with HCTZ also. The most serious interaction is the drug dofetilide. Mixing these drugs can lead to lethal arrhythmias. Other drugs that may interact include ACE inhibitors, allopurinol, anesthetics, anticholinergics, some antidiabetic agents, anticoagulants, corticosteroids, and lithium, to name just a few. The drug should be given in the morning. It's important to provide easy access to a restroom because this drug makes you urinate. So we need to monitor body weight, patient's vitals, their intake and their output, and their electrolytes. The patient should be instructed to start a low-salt diet and to add some extra potassium-containing foods into their diet. So bananas, potatoes, apricots, orange juice. The patient should be taught to change position slowly because orthostatic hypotension can develop, and that they need to come in for follow-up lab work because we need to monitor those electrolytes and make sure their potassium isn't low. We should also be instructing the patients the signs and symptoms of hypokalemia and when they should call the doctor. So some other drugs that are part of this category: Diuryl, Natriuretin, Renice, and Enduron. And you see the difference there. The brand names are capitalized and the generic names of the drugs are not capitalized. And again, they're pregnancy category C drugs, not approved for children or breastfeeding mothers. Loop diuretics. These are powerful diuretics that work on the loop of Henle and inhibit sodium and chloride resorption. This increases the excretion of water, sodium, potassium, and chloride in the urine. These can filter 20 to 25% of sodium out to be excreted. They can be given orally or by IV. They are highly protein bound, which means that they bind to the protein in the drug. So if we have less protein in our body, they have nothing to bind to and more free, so they have a higher effect. These diuretics are metabolized by the liver and excreted by the kidneys. They cross the placenta and are excreted into breast milk. Lasix, or furosemide, which is the prototype for this class, is effective in treating peripheral edema from CHF and hepatic or renal diseases. Also to treat pulmonary edema and hypertension. Lasix is the first choice of treatment for hypertension in patients with renal disease. So HCTZ is the first choice treatment for hypertension, but if someone has kidney problems, they can't have thiazide diuretics because they can damage kidneys. So then we go to Lasix as the second choice. So contraindications, Lasix should be used with caution in patients who have a sulfonamide allergy or those with anuria related to renal failure. We should also use caution in patients with lupus. Most of these adverse effects are also related to fluid and electrolyte imbalances. Things like dizziness, orthostatic hypotension, and vertigo are common. Rapid IV infusion can cause ototoxicity and lead to deafness. Symptoms of ototoxicity include tinnitus, which is ringing in the ears, vertigo, feeling of fullness in the ear, and nurses need to be aware that older adults are more sensitive to fluid loss. So we need to watch older adults especially for signs and symptoms of dehydration. Those signs include dry mouth, thirst, weakness, lethargy, muscle cramps, oliguria, which means decreased urine output, and tachycardia. Nurses need to monitor vital signs and get the patient's weight. And we need to know their past medication history because Lasix can interact with many drugs, including ACE inhibitors, aminoglycosides, anticoagulants, beta blockers, corticosteroids, sulfonylureas, lithium, and muscle relaxants. It's also a pregnancy category C drug, so we need to know if our patient is pregnant. It should be used cautiously with premature infants, but it is safe to give children at a low dose. And the patient should experience a reduction in edema and blood pressure for the dose to be therapeutic. We need to monitor their labs, their CBC, their electrolytes, their uric acid, to maintain those at normal level. For education-wise, we need to teach our patients to take this medication with food or milk and report any shortness of breath. Some other loop diuretics: Demodex, Edicrin, and Bumix. Demodex is metabolized differently than Lasix. Edicrin is not a sulfonamide and can be used to treat edema in those with a sulfonamide allergy, but is not approved for children. Bumix is more potent and can cause profound diuresis and electrolyte loss. It is only used to treat edema, not blood pressure, and is not approved for children. Potassium-sparing diuretics. Direnium, or triamterene, is the prototype for this class. Acts on the late distal tubule and collecting duct. It promotes the retention of potassium and magnesium. These diuretics promote water and sodium excretion and potassium reabsorption by inhibiting the transport of sodium in the distal tubules. They have a weak effect on diuresis and blood pressure alone, but are often used in combination with either a loop or a thiazide diuretic. Potassium-sparing diuretics only cause 1 to 2% of sodium that is filtered to be excreted. Triamterene is used to help manage edema and hypertension. It is an oral medication and is metabolized in the liver and excreted by the kidneys. Triamterene crosses the placenta and is secreted in breast milk and is not approved for children. It is contraindicated in patients who have hyperkalemia, which high potassium, anuria, renal disease, or liver disease, and it should be used with caution in patients with electrolyte imbalances, kidney stones, diabetes, and those with low folic acid. Adverse effects include hyperkalemia or other electrolyte imbalances. It can be nephrotoxic and can lead to acute renal failure. Some other side effects include jaundice, fatigue, dizziness, and headache, along with GI issues. Triamterene interacts with multiple drugs and should be used with caution in patients who take ACE inhibitors, amantadine, cimetidine, indomethacin, or any drugs that will increase potassium. We need to assess the patient's medication and allergy history. We needed to monitor their blood pressure, their edema, and weight. And we need to monitor for signs and symptoms of hyperkalemia: nausea, diarrhea, muscle weakness, weak pulse, cardiac arrhythmias. Triamterene is effective if the blood pressure or edema is reduced and has not caused hyperkalemia. This drug should be taken with food. We need to make sure we're teaching our patients those signs and symptoms of hyperkalemia and to avoid foods that are high in potassium. So some other drugs that go along with this class: Midamor, Inspira, and Aldactone. Midamor is approved especially for CHF. It can reduce polyuria caused by lithium without increasing lithium levels. Inspira and Aldactone work by blocking aldosterone receptors and are used to treat both CHF and hypertension. Aldactone is also used to treat hyperaldosteronism, hirsutism, premenstrual syndrome, and acne. It can cause menstrual irregularities, impotence, and gynecomastia. Osmotic diuretics are our last class of diuretics. The prototype for this class is mannitol or osmotrol. The mannitol acts on the entire renal tubule. It impairs normal tubule water reabsorption and impairs the kidney's concentrating ability. So osmotic diuretics increase osmotic pressure and pull fluids from tissues into the vascular space. So they are not reabsorbed by the tubules, so they prevent water, sodium, and chloride reabsorption. Mannitol is used to prevent and treat acute renal failure. It is used to reduce intracranial pressure and to reduce intraocular pressure. It can also be used to promote renal excretion of toxic drugs as an irrigant after transurethral procedures. Osmotrol can be given IV or as a urinary irrigant. It crosses the placenta and is secreted in breast milk. So what they mean by a transurethral procedure, if someone has prostate cancer or needs to have, they have an enlarged prostate and they need to have their urethra opened, they can use mannitol as an irrigant for the bladder after that transurethral procedure, given through the ureter. Contraindications to osmotic diuretics. It's contraindicated in renal disease, in pulmonary congestion, and for anyone with intracranial bleeding. It should not be used in someone who is severely dehydrated. Osmotrol should be used with caution in patients with CHF, renal disease, and electrolyte imbalance. Adverse effects from this drug include hyponatremia, so low sodium, either hyper or hypovolemia, CHF, or pulmonary edema related to sudden expansion of extracellular fluid due to high dose or lack of kidney function. We need to assess our patient for pregnancy or breastfeeding, and we need to be aware that elderly patients are at increased risk for problems related to rapid fluid loss. We need to monitor hourly urine output. Typically, an indwelling catheter is required with mannitol. The drug rate should be adjusted to maintain the urine output of 30 to 50 mLs per hour. The drug is therapeutic when urinary output increases and intracranial or intraocular pressure decreases without patient complications. The patient should be taught to report chest pain or shortness of breath and signs of dehydration. Osmotrol does not interact with any foods and does not have any serious drug interactions. Other osmotic diuretics include glycerin, osmotic, and uracil. Glycerin is an oral drug used to reduce intraocular pressure for glaucoma and prior to eye surgery. It can cause severe dehydration, cardiac arrhythmias, and hyperosmolar non-ketotic coma. As a suppository, it's used to relieve constipation. Osmotic is used for decreasing intraocular pressure and glaucoma relief. And uracil is administered by IV infusion to decrease intracranial pressure, and it has been used to induce abortions. Carbonic anhydrase inhibitors are mostly used to treat intraocular pressure. Carbonic anhydrase is an enzyme that assists in renal excretion of acid in urine and in reabsorption of sodium and potassium in the kidneys. This class of drugs is used to treat increased intraocular pressure. Diamox sequels is the prototype drug for this class. We'll just call it Diamox. It's used to treat glaucoma. It is used as an adjunct to treat epilepsy and to prevent mountain sickness. It can be given orally or via IV. It is absorbed into the GI tract and is excreted by the kidneys. Diamox inhibits carbonic anhydrase which is needed for active transport of ions in the proximal tubule. This inhibition results in decreased hydrogen ion secretion by the tubules and increased excretion of sodium, potassium, bicarbonate, and water. This reduces the pH of body fluids, inhibits carbonic anhydrase, also inhibits formation of aqueous humor, and lowers intraocular pressure. It is a pregnancy category C drug and is secreted in breast milk. They do not know if it is safe for use in children. Contraindications to using carbonic anhydrase inhibitors. Patients with hyponatremia, hypokalemia, kidney or liver disease, and pulmonary obstruction. It should be used cautiously for patients with adrenocortical insufficiency because these patients are more susceptible to electrolyte imbalance. Adverse effects include GI-related problems. Symptoms of overdose include paresthesias, ataxia, tremor, and tinnitus. It interacts with cyclosporin, diflucanol, primidone, and salicylates, which are aspirin. Nurse should be aware of any sulfonamide or thiazide diuretic allergy because the patient could have a reaction also to this drug. Dosage in the elderly may need to be reduced. The patient needs to be aware of the importance of follow-up lab work to check for CBC and electrolyte levels. They should also be taught to notify their doctor if they have any signs of blood abnormalities like easy bruising or petechiae, or if they have any signs of metabolic acidosis like numbness in their extremities, rapid respirations, abdominal pain, or tinnitus. We need to make sure that we're watching for hypotension and orthostatic changes. Sometimes for this drug to be therapeutic, so for it to work as we want it to work, but without the patients having a lot of other issues, we might only have them take it every other day or every 2 days. So we can have the good therapeutic effect of the drug without all of the adverse effects that go with it. Other carbonic anhydrase inhibitors, neptazane, azopt, or trusopt oximeter. Neptazane is used to treat intraocular pressure, but it is not effective as Diamox. Azopt and trusopt are both ophthalmic drops, so eye drops, typically used for glaucoma. Anticholinergics. Typically, these are used to treat overactive bladder. In this case, these are used to treat overactive bladder. Receptors for cholinergic drugs are found in the bladder. When these cholinergic receptors are blocked, the bladder contraction cannot occur. This decreases urinary output. And so these drugs are used to treat overactive bladder. Detrol, or tolterodine, is the prototype drug for this class. Used to treat overactive bladder, it targets those receptors in the bladder and decreases the ability of the bladder to contract. Detrol is an oral drug, and it treats the symptoms of urinary frequency, urinary urgency, and urge incontinence in patients with overactive bladder. Cholinergic receptors are found both in salivary glands and in the bladder, but Detrol has a selective preference for the bladder receptors. Blocking those receptors in the bladder, Detrol has a profound effect on bladder function. It is contraindicated in patients with urinary or gastric retention, or those with uncontrolled narrow-angle glaucoma. It should be used with caution in patients with renal or hepatic impairment, with approximately half of the dosage used. It should also be used cautiously in patients that have bladder obstruction. The most common side effect is dry mouth, which is, obviously because the receptors are both in the mouth and in the bladder. It can also cause constipation, abnormal vision, urinary retention, headache, and dry eyes. It can cause drug interactions with fluoxetine and some antibiotics like erythromycin and clarithromycin, or antifungals like ketoconazole and miconazole. Nurses need to assess for bladder outlet obstruction, urinary retention, renal or hepatic impairment, and glaucoma. Patient education should include teaching them to keep a diary to record episodes of incontinence and frequency of urination to help assess if therapy is effective. They can be taught ways to deal with dry mouth and when to call a doctor. They should notify their doctor if they have any urinary or GI retention or any visual changes. Other anticholinergic agents, oxytrol, Enablex, Vesicare, Cinctura, Urispas. Oxytrol is a transdermal administration and is pregnancy category B. Enablex, Vesicare, and Cinctura have longer half-lives, so they can only have to be given once a day. Urispas is used for symptomatic relief of cystitis, urethritis, and prostatitis. I have a handout for y'all that has some levels of edema, how to measure edema, how do you rate it, just a little reminder on how to do that. I also, on that handout that I'll attach, I have broken down, so there's your edema. You have 1+ pitting edema is a 2 millimeter depression, barely detectable with immediate rebound. 2+ pitting edema, 4 millimeter dent that takes a few seconds to rebound. 3+ pitting edema, 6 millimeter dent, 10 to 12 seconds to rebound. And then 4+ pitting edema is that 8 millimeter dent that takes more than 20 seconds to rebound. So that's how we judge how much edema our patient has. And we do that by applying pressure to the swollen area for at least 5 seconds. So that's what you would see. I also put on this handout the stages of chronic kidney disease, kind of to break that down for you. So this GFR is the glomerular filtration rate of the kidney. Typically, stage 2 here, this is mild kidney disease. It goes from stage 1, which is obviously the very beginning, to stage 5, which is end-stage renal disease. At this stage, people are going to need dialysis or a kidney transplant to stay alive. And just a breakdown of the other drugs that we talked about, the carbonic anhydrase inhibitors to treat glaucoma, the anticholinergics to treat overactive bladder, and I just kind of listed them there. And then the diuretics I broke down just to kind of give you a little sort of cheat sheet to look at. So the thiazide, the loop, the potassium sparing, the osmotic diuretics. So just a little handy handout for those of you who need either a refresher or this is the first time seeing it. And then I have some questions that I'm going to also upload, some practice questions for you guys to look at. So thank you. I hope today's class was helpful. I will see you next time around. Have a good day.